Right, good evening everyone. My name is Chrissy Kelly. I'm the founder of AbScent and welcome to this Tuesday evening Zoom webinar. Normally, as you probably know, I hold these events every other Tuesday, but this is a busy time for anyone who is involved in trying to help people with smell loss after COVID-19. And so today, as a sort of extra one in between, I've got Professor Claire Hopkins with me. And Professor Hopkins is the president of the British Chronological Society. So welcome, Claire. It's lovely to have you again. Thank you so much for coming back and doing a webinar with us.
So thank you very much, Chrissy, for the opportunity to come back and speak to you all. I hope that I will be able to answer some of the questions that certainly my patients put to me. And in an attempt to try and make this as useful as possible, I've taken the liberty of looking through some of the Facebook posts to try and pick out questions that seem to come up repeatedly. So I will try and answer those as best I can, giving you some of the available evidence. And in order to help, I've put together some slides that Chrissy will post onto the website afterwards, so you can come back and look at some of the things in a slide form, which might be easier than replaying some of the videos. So I'm sharing my slides and we'll work through those.
That's great.
I'm going to really kind of update on things, but there will be plenty of time at the end to answer any questions. And I found this on the Facebook group. I know that Chrissy asked you all to give 3 things that you wanted from your ENT surgeon. So I'm afraid I can't give you cuddles and martinis, but I will try and cover as many of the other things tonight. And I really like what's in the centre, and that's how I'll finish my talk tonight. And you really should be hopeful. There is lots to be optimistic about, and I will try and share some of that with you. But I'll certainly share some of the evidence that we've accumulated over the last 4 months, mostly with the help of people like yourselves helping to complete surveys and different research projects. So the first question that everyone asks, and I hear repeatedly, is, was it really COVID? And the answer is that if you have lost your sense of smell and taste really since January, February of this year, in the absence of any other cause, and the types of things that can cause smell loss other than COVID are a recent head injury, drug-related, there are a small number of drugs that can cause loss of sense of smell, recent nasal surgery, nasal polyps, and this tends to cause a gradual onset of blockage which comes and goes. But you'd likely know about all of these things. So if you have basically suddenly lost your sense of smell and taste, having not had problems before, I can say with almost certainty that it was COVID related. What we know from patients that we studied who suddenly lost their sense of smell and taste, we were able to recruit patients into a study in Belgium, and we tested them with a swab test within the first 5 days, and then we also tested them with antibody testing, is that more than 98% of those people tested positive. And given that there's quite a high false negative rate, we can really be quite confident that almost everybody losing their sense of smell and taste at the moment has COVID-19. And really only other causes in the small print out of those things that I've mentioned that you'd know about are other viruses, and there are other strains of coronavirus that can also cause you to lose your sense of smell and taste. So that means that loss of smell and taste is more reliable than a COVID test. And I see quite a few people talking about in the Facebook group, have I got COVID? And the answer is almost certainly yes, and you do need to self-isolate. And I would suggest that even if you get a negative swab, you should still assume that it's COVID-19 and self-isolate for 7 days. So nasal swabs, and you can see this picture on the left of someone having a swab, are only really reliable in the first 5 days from when your symptoms first start, and they become almost useless after 12 days. And even then, about 30% have a false negative test. So even if you have COVID, there's only a 70% chance that that swab test will pick it up. And that's because the swab test is often done badly. And this is a good example. You can see the swab is going straight up here and causing the poor patient to pull a face, and actually it should go straight back into the nose. So this is a really good example of bad swab technique that was taken from our UK NHS website. And if they can't get it right there, there's very little chance that other people are going to do it. So it will fail to pick up cases. So don't assume that a negative test is a definite negative response. Now, what we also know from swab tests is that about 30% of people continue to test positive on a swab test many weeks after. And that's because you get some dead virus shedding through the nose. And what we found looking at these patients is it doesn't mean you're still infected, it's simply that the body is clearing out the virus. So I think we should be less concerned in patients who continue to test positive. It doesn't mean that you still have an active infection. So as I said at the bottom, given the rate of false negative, I think losing your sense of smell and taste is actually the most reliable sign of COVID-19, and you almost don't need a test. But obviously, if they are available, it's nice to have that confirmation. So the next question that we've seen a lot is, well, you know, what we know certainly in the UK around March and April, where many people lost their sense of smell and taste, it simply wasn't possible to get a test at that point. We were only testing people with cough and fever who had to be hospitalised. So is it worth going back and paying for an antibody test? Here you can see an antibody test. For any of those that haven't taken one, it's a little bit like a pregnancy test, except you put a spot of blood down this end and you wait for the lines to appear. And this test shows that the controlled line is positive, and this patient's definitely been exposed because they have both IgG and IgM antibodies. But is it worth paying for this? Well, the answer to that is probably not. Now, antibodies take about 2 to 3 weeks to develop, and we know that the level of antibody response is related to the severity of illness. So most people who are sick enough to be hospitalised will develop antibodies about 2 to 3 weeks later. But of the people with more mild disease, only about 85% will develop detectable levels of antibodies even 3 weeks after. And what we found is that antibody levels drop by about 40% between that first test and if you have a test 8 weeks later. So this is some data from Guy's and St Thomas's Hospital where I work. And in red, you can see the antibody results for some patients who were hospitalised. And you can see that straight after the illness, the antibody levels are quite high, but over time in the first 2 months, they start to drop. The lines in black were taken from healthcare workers, and many of us had very mild infections or asymptomatic infections, and many lost their sense of smell and taste, but were otherwise quite well. And here you can see the antibody levels start much lower, and over time they drop, and this is the detectable level. So you can see in several of these patients, even as early as 30 days after illness, the antibody test is turning negative. So a negative antibody test doesn't rule out COVID infection. And in fact, by 2 months after infection, about 50% of people with mild COVID infection, as in not hospitalised, will test negative on an antibody test. So it's useful if it's positive. There are very few other things that will give you a false positive result, other than perhaps some other coronavirus infections in the past. But it doesn't really help us if it's negative. Now, some patients really like that validation of knowing that the test was positive, but it can be really frustrating if you had all the right signs and symptoms, you've lost your smell and taste, and that test comes back negative. So I would think very carefully before spending a lot of money on one of those antibody tests. And the question that follows that when we show the antibody levels dropping is, you know, well, does that mean I can get it again? And the answer to that is, well, at the moment, we don't know absolutely for sure, but I think it's pretty unlikely. You know, there have been over 6 million reported recovered cases worldwide, and we actually have very few examples of anybody getting a second infection or possibly a reactivation. And we know that antibody-mediated immunity is only a very small part of the immune response. If you imagine a defence force, we will have Army, Navy, Royal Air Force, all different kinds. And we can think about the immune system in a very similar way. The antibody response is just a small part of our body's immune response, and there are many other things. And you may have heard about T-cell immunity, and we think particularly with coronaviruses, that's quite important. And there was a very useful paper published in Nature, which is one of our leading scientific journals, only a week ago. And they found that they could demonstrate memory T-cells for COVID-19 in all the survivors that they tested. And actually, really interestingly and most reassuringly, they tested survivors from the first Sars outbreak, and this was around 2003. And what they found in this group of patients is that they also had memory T cells to SARS-1, and these were lasting, 17 years after infection. And those memory T cells are armed and ready to fight any future exposure to COVID-19. So, it is unlikely, we think, at this point in time that you'll get infected again. That doesn't mean you should stop taking all the right precautions, but you should take some comfort from knowing that you are likely immune. The other question that follows on for that is, well, am I still infectious? I've mentioned already that having persistent positive swab tests, we don't think means that you're infectious, and we have looked at how infective the viral particles are in the nose, and by 7 days you're almost non-infectious, and at 14 days you can be quite confident that you're not likely to spread infection. So you should take self-isolation from the time of onset of symptoms and not rely on positive swab tests, and particularly you don't have to keep self-isolating if you have persistent loss of smell and taste. because persistent anosmia isn't related to ongoing infection. It's just a failure of recovery of the nerves, and we'll come back to that. We know, as many of you will be experiencing now, that patients have long-lasting symptoms, and there's now something that we describe as long COVID, this fluctuating long tail of response as people are recovering, but you're not infectious at that point. So the next question I came across, and certainly this has come up quite a lot in the last few days, is, well, do I need to see a doctor? Now, you've already taken the most important step in your recovery, and that is finding AbScent and patient support groups. And time, support and smell training are by far the most important things that you can be doing. And so I'm sure that you've all seen the smell training pages, and I would certainly recommend that you start this if you haven't done so already. Now, if you see a primary care doctor, they might be able to prescribe steroids, either in a form of drops or rinses, or oral steroids. And this is probably worthwhile if your anosmia has gone on for about 4 to 8 weeks, and we'll come back to that. You only need to see an ENT surgeon if you still have nasal obstruction 4 to 8 weeks later, or if things haven't improved in 3 months. And I'm afraid it's not because we have a magic answer. Hopefully you will find all the answers to treatment on AbScent and tonight, but really so that we can exclude any other underlying causes, such as nasal polyps. And in the last 4 months, I've only found one patient in all the ones that I've seen that have turned out to have nasal polyps rather than COVID anosmia. But it's worth ruling that out more for peace of mind than anything else. Obviously, the next problem is, and many of you have expressed your frustration already, is that, you know, well, that's all very well, but my doctor doesn't seem to know anything about anosmia. And, you know, considering how difficult it is for GPs, they have had to accumulate a huge amount of knowledge about COVID and its impact on the whole body. And it is very difficult for them to keep up to date. So it's perhaps not surprising that you have become an expert in this and may know more about it than them. And they will recognise that, and they won't mind if you take along some of the knowledge that we've gained in months or two, and you'll be helping them out too. But we're also doing our bit to make sure that GPs and ENT surgeons are up to date. So this is an article we published in the BMJ, the British Medical Journal, last Friday, and it basically talks a GP through what to expect in a 10-minute consultation, what they should be asking and what they should be sharing with you. And this has landed on the doorstep of pretty much every GP in the country, so hopefully they will learn more. We've done a lot of webinars, we've got quite a lot of information on our ENT UK website for ENT surgeons. So we are doing our bit to make sure that if you do see a doctor, they will know what to do and help. But don't be afraid to take along the guidelines with you and say, you know, I realise it must be very difficult for you and you're very busy. I wonder if you wouldn't mind referring me, because that's what is said by ENT UK. And many of them will be happy to do that. So these are our British Rhinological Society guidelines. These are available for anyone to download from the ENT UK website, and we're trying to signpost GPs and ENT surgeons to these guidelines. And I'll run through those a little bit more. Another question that many people have asked is, well, do I need an MRI? And at the moment, people are finding it difficult to access GPs and get referrals, and therefore they're wondering whether they should pay for them privately. And I would say almost certainly you don't need one, and I would really recommend against paying for one privately. And that's because, first of all, an MRI can't diagnose nerve damage. So an MRI can rule out other causes, but it doesn't really tell us why COVID has caused your anosmia. And it also doesn't tell us how best to treat you or predict your recovery. And when I was a medical student, we were really taught that we should only order a test if it changes our management, if it makes the diagnosis, or if it gives us useful information on recovery. Now, if you've had other symptoms of COVID, if you've had a positive test, we know it's COVID, so we're not looking for other causes. And the chance of finding something unexpected is extremely rare. It's about 1 in 3 million people might have something else causing their anosmia. And we can usually see that in the nose, which is why we're recommending you should see ENT if it's gone on for more than 3 months, but an endoscopy is likely to be enough. It doesn't tell us very much about recovery, but it's useful really for research purposes. And we've undertaken MRIs in some patients with COVID anosmia to see what's going on. And here's an example. On the left, you can see a patient early on, and these are the olfactory bulbs. This is the nasal cavity, these are the eyes, this is the brain, and the olfactory bulbs are highlighted in red. And what you see in the early stages, about 2 to 3 weeks in, is that the bulbs become swollen and have what we call increased intensity. That is, they show signs of inflammation. But when you scan patients later on, and you can follow patients. Within 3 to 4 weeks, that sign of inflammation and swelling has already disappeared. So unless you have a series of MRIs, it's very difficult to compare the size of the olfactory bulb. And as I said, it doesn't give us useful information on whether you're likely to recover or how we should treat you. So it doesn't really add anything to your care. Now, having an MRI isn't much fun. It takes about an hour. It's very noisy and claustrophobic. And for the vast majority of people, it's simply not going to add anything to our management. And there are very few cases where I consider an MRI, and that's if the history is very atypical. There's no clear evidence that it was COVID related, and in those cases we might still scan. But for the vast majority of people, it really won't help very much with your care. And what the scans have told us is a little bit about the mechanism of anosmia. And what we think is that actually most people with COVID anosmia fall into two very different groups. And I think there's some evidence of that in the Facebook group. There's a group that lose their sense of smell very quickly, but actually have pretty much recovered back to normal within 2 to 3 weeks. And that's about 50% of people. And in this group, we think that it's due to injury to the epithelium, the lining of the nose in the olfactory cleft area, due to injury to the supporting cells, which are known to express the binding receptors for COVID. This will cause some swelling in that area, but the cell nerves themselves don't die. And this is likely to recover quite quickly. And we've got evidence from CT scans to show swelling up in that area of the olfactory cleft in the first 2 weeks. And we've got some results from nasal scraping studies where we've shown injury to the epithelium. But the other 50%, and I imagine most people tuning in tonight will fall into this group, have more persistent anosmia. And in this group, we've shown inflammation on the MRI in the olfactory bulb. So we think in this group that there is a more significant loss of the lining of the nose, but also injury and apoptosis to the olfactory nerves itself. And this is supported by the MRI studies. And in a very small number of patients with severe disease who have died, we've got some autopsy evidence to support that as well. So we've got two different mechanisms going on, and there's no easy way to predict at day one which of those two groups you fall into. So certainly the first 2 to 3 weeks, you'll likely know whether it's going to be the first group and you're back to square one, or you're in for a slightly longer journey to recovery. And you shouldn't believe everything that's been written in the papers. There have been loads of newspaper articles in the last 2 to 3 days. I've seen copies in the Mirror, in the Sun, USA Today, here is an example, saying that the good news is it's not permanent and there's no nerve injury. And the headlines are really interesting. You know, it says, you know, we thought that there was inflammation in the olfactory bulb, but that turned out to be wrong. But the newspaper articles bear absolutely no relation to the scientific paper that they're talking about. Now, the scientific paper was first published in March, so it's actually been around for 4 months, but it's taken 4 months to get into print, which suggests that there have been some questions about the validity of the research. But actually what the paper that everyone's talking about says is that all they've done is look at where the receptors are expressed in mice and primates, and they've got a couple of human samples as well. These are animals that haven't been exposed to COVID infection, and what they found is that the ACE2 receptors, where the COVID binds, are found in the supporting cells of the olfactory epithelium, which we have known before anyway from the previous COVID viruses. So that doesn't tell us anything new. But what they go on to conclude from this paper is that it's okay, if COVID attacks, it's probably only going to damage the supporting cells and not the nerves. But this is just a hypothesis, a theory. They haven't tested it at all in the paper. They have got no results from anyone who's been exposed to COVID. So it's just something that they're assuming without any evidence to back it up. And it's amazing how that assumption has been reported in all the headlines. Mm-hmm. So, you know, that definitely doesn't show that it can't damage the nerve. And we do have some evidence that suggests it probably does. And there's lots more evidence that will come out. But as I said, we think that in the majority of patients with longer lasting anosmia, it is due to injury to the olfactory nerves that needs to recover. And that's why recovery is taking 8, 12, 16 weeks in many patients. So moving forward, and the most important bit for you all, a little bit about the evidence on recovery and treatment. And the first thing really to highlight is that you are all survivors. It may be really hard to see the silver lining at the moment, but you are all here, hopefully in reasonably good health. And I'm not underestimating the impact of losing your sense of smell and taste at all, but you have all survived the infection. And there is a theory that your anosmia is one of the reasons that you've survived, and that it's protected you from a more severe infection. So there's something called apoptosis, or programmed cell death. And we think that if those cell nerves die, it stops the virus progressing along the olfactory nerves into the central nervous system, where it can cause significantly more damage. And it's probably quite a good educated bet to take. This virus is what we call neurotropic. It can gain entry through the olfactory nerves, but olfactory nerves do regenerate. So it's quite a good idea to shut them off and stop the virus gaining entry on the grounds that they're very likely to recover. And there's some mice models that support this theory. So there are some studies done about 20 years ago using influenza A virus, and mice that were inoculated with the virus. If the olfactory nerves died, the mice survived the infection. But if the olfactory nerves didn't die, the virus was able to gain entry into the central nervous system and all the mice died. And so it seems that you may have actually done a very clever thing by severing your olfactory nerves, and it's allowed you to survive what might have been a more severe infection. So this is really just a theory, but I think it's worth thinking out. Perhaps you have adapted very cleverly to this infection, and that's why you are here now. But there is every chance that those olfactory nerves will recover. And so the million-dollar question is, will I recover? Well, I think the answer is, it is very likely. I can't give you 100% certainty, but I think it is very likely that most of you will make a good recovery. So these are some of the studies that we published. This is one of the first studies that we published, and this looked at the difference between 1 week and patients answering a questionnaire a week later. And what you see, this was collected really right at the beginning of the pandemic in the UK at the end of March. At my first questionnaire, the vast majority of patients that answered had complete loss of smell and taste. And even a week later, 4/5 of patients have already started to see signs of improvement. And only 1/5 of that original group still have complete loss in just a week. So this, as I said, that group that makes a very early recovery will predominate in this study. We then looked at patients with 4-week and 8-week follow-up. And here you can see the group with altered smell and taste at baseline. And it's dropped from 60% to 40% to only 20% at 8 weeks. And again, if we look at the rating, it's as bad as it can be or severe in about 1/3 of patients, dropping down to only 10% at 4 weeks and dropping down to 3% at 8 weeks. So that's, really encouraging for the majority of people. Now, many people will be saying, well, that's all very well, but I'm still down here, and what about me? But there is still a very good chance we think that you'll recover. This is another study we did doing objective testing or sniffing stick tests, basically to look at olfactory thresholds. So with this, we can actually get a score. And again, we've studied patients every 10 days. So you can see the average score is improving throughout the first 2 months, and it continues to improve. And the number of patients with complete loss has dropped from 40% on the objective testing to only 2% at 2 months. And again, this is really encouraging. We haven't seen it plateau. We're continuing to follow patients out to 90 days and beyond, and patients are continuing to show signs of recovery. And we really do think there is a very good chance that you will make a good, if not full, recovery. So with other viruses, we've seen improvements continue for months, if not years. So if you take patients who have complete loss of smell and taste at 3 months, another 1/3 have recovered by 6 months, and 2/3 have recovered by 18 months. It's not a quick fix. I know that many of you will be frustrated that it might take so long, but the important thing is to remain hopeful, and you will likely see continued improvement. It can be really difficult to judge that when the improvement is slow and small. And so doing that home smell testing once every 3 months can be worthwhile, just to reassure yourself that there may be signs of improvement. Now, Prosmia seems to be a particular feature with COVID and Osmia. It's reported in about 50% of patients with post-viral loss because of other viruses. And I think perhaps is even higher with COVID, but we don't have accurate figures for that. But again, it's an encouraging sign, and we strongly believe that it represents recovery. So there were some surgical procedures done in the 70s for patients with very severe parosmia, where the olfactory nerves were actually stripped out and removed. And when they were looked at under the microscope, what they could see was that actually the olfactory nerves simply hadn't become fully functioning. They were an immature form. And we think that with time, these will progress to more mature, properly functioning neurons, particularly with the help of smell training, and the parosmia will settle. There are also some functional MRI studies. And what you can see in patients with parosmia is there's an abnormal pattern of activation. So normally when we smell, it lights up an area in the brain called the hippocampus, which is strongly involved with memories. And in some patients with parosmia, it latches onto the wrong area and causes unpleasant sensations or smells. And again, smell training, we think, can help redirect the proper central communication in the central nervous system and help the parosmia fade away. Now, it can cause significant distress, and I'm certainly not underestimating the impact that it can have. And in very severe cases, there is some medication, particularly anti-epileptic medication. So if you're really struggling with it, unable to eat with severe nausea, it may be worth speaking to your GP or a neurologist. But what we don't understand is whether those medications will actually delay recovery. And because for many people it will be a temporary stage, we're trying to hold those medications in reserve for only people that are really struggling with their parosmia. But there is something to fall back on if you need. And so last thing I'm just going to talk about is treatments. So we've already mentioned smell training. Time is certainly the greatest healer in this respect. It is definitely worth stopping smoking, although I think parosmia will put most people off anyway. And we'll talk a little bit about the different medications that you might use. And what I see a lot on the Facebook group is that patients who have made a quick recovery have shared the tablets that they've been taking, and there's often a whole combination of different supplements and vitamins and sometimes prescribed medications. And I can understand how if someone seems to recover very quickly, it's tempting to want to do the same. So I'm just going to talk very briefly about how we interpret evidence in general, and then we'll talk about the evidence for some of those medications. And this comes from a talk that I give to medical students. I apologise that I'm going a little bit off topic here, but I thought it might be helpful to share it. So what can and should we take from research and reports of treatments? And I'm just going to share some of the challenges in how we interpret those treatment effects. So if you imagine a magic treatment called Grow More Magic Beans, and the trial result says that these are fantastic because 100% of children participating in a clinical trial showed faster growth when they took magic beans over a 6-week period. And these are over-the-counter tablets. They contain multivitamins and minerals that are essential for growth. And this sounds like a great supplement. So you might be tempted to go out and buy some magic beans for your children if you want them to grow faster. Now, when I look at a clinical trial, there are certain questions that I ask myself before I assume whether the trial is reliable. So I want to know how the study was conducted. I want to know if there was a control arm, if there was a group of patients or participants who didn't take the treatment, so we can compare the two arms, and that's really important, and I'll come back to that. We want to look at how patients were allocated to the two different treatment arms. Were there differences in the two groups? Did the less severe patients get one treatment and the more severe patients get another? Was it blinded? And that's really important. Did the participants know, and did the people making the measurements know which treatment arm they were in? Because that can bias your results. Someone assessing treatment might say that one arm was better if they want that arm to work. How did they record whether it worked or not? What outcome measure was used? Did all the participants that started off finish the study? You know, if only half the patients finish, you want to know what happens to the other half that drop out. And what we tend to come out with at the end of a trial is something called the number needed to treat. How many patients do I need to treat to help one patient? And also importantly, how many patients do I need to treat to harm one patient? And you always want, obviously, the number that you're going to treat, the number needed to treat, to be higher than the number that might be at risk of harm from taking a part. So if I come back to my magic beans, well, when we look at a study, and this is a typical example of a scientific study, so 200 parents of year 9 pupils were given free samples the last day of the summer term. Everybody was given the active treatment. They were red tablets, and red tablets we know have a greater placebo effect than other coloured medications. Now, parents were offered 3 more packs if they came back at the end of the holiday and gave a questionnaire. So there's a bit of an incentive. If you thought they were good, you might want some more, you'd be more likely to fill in the questionnaire. Only 10% of patients actually came back with completed questionnaires at the end of the summer. And they all said that their children grew faster this summer than they did the previous summer. So, you know, you could say that they didn't lie about the results, but actually only 10% finished. They didn't use any measurements. They just asked the parents if they had to buy longer trousers. And actually what they didn't record, because it wasn't in the questionnaires, was that 15% of the children who took part had to stop taking them as they had a severe allergic reaction. And this is made up, but this is the kind of thing that we might see in a clinical trial. And So what you should all be thinking is, well, of course, this is a stupid trial because children always grow. You know, most children will have grown over the summer holiday, and actually pupils in year 9 tend to grow faster than pupils in year 8. So everyone will have grown more this year than they did before. They've hit a growth spurt. The rate of growth wasn't measured. They just relied on parents. Only 10% completed the questionnaire, and therefore the 90% who didn't may have got no response. There was no control arm to compare it to. There were incentives to complete the study, and 1 in 7 had harmful side effects and only 1 in 10 benefited. So actually, when we start to question the study, what seemed like a really good magic pill turns out probably not to be very good. And we all know that Jack and the Beanstalk was a fairy story, and there's no such thing as magic beans, but this reflects what we see in many trials. And if you're the parent of a child who is very short and you're desperate for them to grow, and that one patient at the school gates is telling you, look, this pill was brilliant, my son grew a foot over the summer holidays, you can see how it's really tempting to want to give it a go, because you think, well, what can the harm be? And this happens in medicine all the time. So this is an example from ENT. Adenoidectomy was once the most common procedure performed in children. Children get recurrent upper respiratory tract infections, snotty noses, recurrent glue ear, and we used to take out their adenoids. And what we saw was in children, after having their adenoids removed, they had fewer infections. So we did it for many years, truly believing that we were doing the right thing for children and their parents, until we did a randomized control trial. And as I said, what we did was, once we followed the adenoid group, you can see that they got better. But as soon as we had a control arm, we found that the control arm got better at exactly the same rate, and adenoidectomy didn't add anything to treatment. And if you think of the recovery rate from loss of sense of smell getting better in the background, there's every chance that some of these people that post that they took all of these medications and they got better would simply have got better by themselves. And so it's very difficult to evaluate the effectiveness of treatments in a condition that has a spontaneous recovery rate. So that's a very long-winded way of saying, you know, just be very careful in how much faith you put in someone sharing their experience, because everybody is different and they might simply have got better having done nothing. Now, that's not to paint a picture of doom and gloom, but it's just to really advise some caution, because some over-the-counter treatments can be harmful. And zinc is a really good example. So there are lots of reasons why we need a normal daily amount of zinc, and it's involved in cell regeneration. So it was certainly thought that zinc supplements might be helpful. And zinc was actually produced as a nasal gel to help people recover from the common cold. And it had to be withdrawn from the market because if you put zinc nasal gel in your nose, it actually causes anosmia. So zinc and other heavy metals at high doses are neurotoxic. They actually damage the olfactory nerves. And if you take a much higher than recommended daily amount of zinc supplements, this can also cause harm. So I see lots of people recommending zinc, multivitamins, and if you double up on some of these things, you actually might be causing more harm than good. So be very careful. Certainly daily multivitamin and mineral is absolutely fine, but make sure you don't double dose on anything, overdose, and always have a look at the side effects of any treatment that you might take. So what we do have randomized trials for, there are some studies that have been evaluated in viral loss, and when compared with spontaneous recovery, the randomized trials, this is good quality medical evidence, show that there is no benefit. And zinc supplements fall into this group. Ginkgo, steroid nasal sprays, that's a Beckinase spray, prescription spray over the counter, have been shown not to be helpful, and oral vitamin A supplements. So they are unlikely to cause you harm, but we know that they are unlikely to be of much benefit. So in all studies, there is improvement in the treatment arm, but it was no better than the placebo group or control arm. There are some studies with randomized control trials that do show benefit. And in this group, we have olfactory training, so we can be really confident that this is the right thing to do. And there are two other medications. There are steroid rinses or steroid drops. Now, these are a liquid form where it can get high up into the olfactory bulb much more effectively. And we think that this may be working because it's better absorbed than you can get from a nasal spray. So it's like taking a small dose of a steroid tablet, and oral steroids themselves. Now, these two are not without risks. Steroid rinse is pretty low risk, but about 1 in 12 will get some nasal bleeding. And oral steroids, if you take for a short period, about 1 in 12 people will get some insomnia or effect on mood, can make them feel quite agitated and edgy. They don't give immediate benefit, so you're not going to take the tablet and find that your sense of smell gets better overnight. But the idea is it's reducing inflammation and edema in the olfactory bulb. It's reducing the risk of any scarring and fibrosis that might prevent those olfactory nerves from regenerating carefully. But you have to consider the risk of side effects, and that's a decision to make with your doctor, either in primary care or in ENT. There are some studies that have been evaluated but haven't been looked at with a control arm. So it suggests benefit, but we're not really sure how much added benefit it gives over natural recovery. And that's alpha lipoic acid. And in this study, there were only 23 patients. 1 in 3 showed significant improvement, and that's about the same as placebo effect. Vitamin A drops. Now, the problem with these is they can cause local irritation, and something that stings and burns in the nose, I would be a little bit concerned about in terms of what it does to the olfactory epithelium. And omega-3 supplements have been looked at in a randomized trial, but not in post-viral loss, but in patients undergoing surgery and radiotherapy. So we think that it might be beneficial, but it hasn't been studied in this group. So these may have benefit, but we're not sure how much benefit they're likely to have. And then these are some of the things that I've seen mentioned where we really don't know. There simply haven't been studies yet, or only animal studies, and that's N-acetylcysteine or NAC, vitamin C, PRP injections, plasma-rich protein injections. There's been a pilot study in only 7 patients. The 2 patients in the pilot study with anosmia didn't improve, but 3 of the 5 patients with mild loss did improve. But again, that's the group we would expect to show most spontaneous recovery. So this is really only in a research setting at the moment. And stem cell implantation, I think, is something to look out for in the future, but it's really only been looked at in animal studies. So again, really in early stages at the moment. The good thing is that the huge increase in prevalence from COVID has meant that it's going to be much more likely to run clinical trials in the future. We're much more likely to get funding for trials, and there's already been a huge acceleration into research. Loss of sense of smell and taste has always been a really neglected area of ENT research. Very few of us have been sort of actively interested in the area, but I think that will change now. And I think we'll also find it much easier to get funding. And we've tried to get funding for trials before. The people on the panel haven't really understood what it's all about. And I'm sure many of you will feel like that. It's hard for your family and friends to empathise and understand how much it impacts on you. But fortunately now, many of the people on funding boards will have experienced it. And it was interesting when we were trying to get anosmia recognised as one of the markers for infection with Public Health England. I was initially told that it wasn't going to be added to the symptoms. And the first few meetings we went to, they were absolutely adamant that it wasn't going to get added, until several members of the SAGE group actually lost their sense of smell and taste and tested positive. And suddenly they realised that this was something that they had to take seriously. So I think, again, there'll be many people now that make decisions on research funding who will have experienced this, and hopefully will be a lot more sympathetic to us in the future. In the last 4 months, there have been 1,750 publications on COVID and anosmia alone, which is amazing. You know, that's in 4 months of time where we've all been very busy with clinical work, but there's been a huge amount of research already. So I think there will be some real breakthroughs that come out of this. And, you know, taking part in trials and answering surveys, I know takes your time, but we're very grateful for that, because that will allow us to push things forward for you moving forward. So you've already made the right steps. You've joined AbScent, and we will use patient support groups like this to keep you up to date. And Chrissy will be the first person to share with you any breakthroughs or any trials that you can take part in. And so I really want to leave you with hope. I think there is every reason that you will make a good recovery. It will be difficult along the way. The fluctuations are very frustrating, disappointing. You can feel as if everything is going in the right direction, and then find that you take several steps back. The prosmia, I know, is bothersome, but think of it as a sign that things are regenerating and recovering. So sort of try as much as you can to look at it as a positive sign. And there will be lots of research going on in the background, lots of people like myself trying to make things better, help GPs and ENT be more aware, and really push research forward to find a cure for you all. So I'm sorry that I've sort of bombarded you all with facts. As I said, I wanted to try and make sure I'd covered all the key points, and I will make my slides available and Chrissy can post them on the website. But hopefully we've got plenty of time to answer any questions that you might have.
Yeah,
Great. Okay. Can I just say, Claire, that was amazing. And I will also have to go back and listen to this again because you really have stuffed a lot of information into that, and just wonderful. Thank you so much. Before we start with the questions and answers, and I see that there's a lot going on in the chat bar, a lot going on in the Q&A. Can I just ask you a few questions of my own, and then I'll make one comment about surveys and patients. You talked about, and this comes up all the time, stem cell research. It does look promising, but could you give us a realistic timeline? You know, when might that sort of trickle down to real life? Are we talking 2 years, 5 years, 7 years, 10? What do you think?
Well, I think it will be quicker now because there will be more interest, but I think it's years. I would put 5 years. You know,
Right.
what we have, well, not me personally, but Tufts and Manel and some of the universities in the States have shown that you can activate stem cells, you can culture them, you can create them in a form that will survive, and when you implant them into animal models, they do seem to survive. Now, obviously, what we need to know is whether they function and at what level they function, and all of that work is still to be done. But I think there'll be increased availability of funding to help drive those studies forward, and it's encouraging. You know, we know that the olfactory nerves have the capacity to regenerate, and there's also really encouraging work using stem cells in spinal cord regeneration, for example, and we know that they can work there. So it's an area to look out for, but not something that's going to give an immediate answer for many people dialing in today.
Right. And the other comment that I wanted to make, which you touched on, is this is really a plea to all of you who are in the audience tonight who are patients. We can't help science move forward unless you respond to surveys. I know you all want to tell your stories, and you want to tell your stories to your doctors, but that's not the way your story gets into the world of science. Science needs data, and to get data from you, we need you to fill out surveys. So every time you see a survey come in, please don't feel that, you know, it's boring or repetitious. We need everyone to answer those surveys and help us to help you. That's the only way it's going to happen. So thank you to all of you who have filled out surveys so far. Right, now without further ado, I'd like to...
On that point, I can't agree enough. You know, within the first weekend after we put the first post out that we thought there was a link between COVID and an Osmia, I had 2,500 people answer a survey in 48 hours, which is unheard of. And that first survey was one of the things that really drove the World Health Organization and other countries to recognize that this was a real thing. And so anyone taking part in these surveys, you're making a real difference to, first of all, our ability to get this recognized and to treat it. So it is really important.
Yeah, absolutely. Right, so now I think we're going to go over to Aidan, who is manning the chat bar and the question and answer. So what do you have for us, Aidan?
Yeah, it's been quite busy over here this evening. I've just been having a look through just now. Maybe quite a nice one to start on is Imogen asks, how many people do we think have been impacted with this since COVID in the UK?
So there are 300,000 confirmed cases of COVID in the UK. That's people who have been able to access testing. And the problem is, for many of you, people that lost their sense of smell and taste in March and April simply couldn't get access to testing. We've looked at a whole number of studies, and in the mild group, 70% lose their sense of smell and taste. In the more severe group, it's about 30%, and it works out to be about 50% overall. If we take the results of antibody testing, then 7% of the population have been exposed to COVID. And if we take the 10% that have longer lasting loss of sense of smell, my back of the envelope calculations is that in the UK at the moment, there are about 400,000 people who still have loss of sense of smell and taste as a result of COVID. So huge numbers of people.
We have a question here from Claire, and obviously parosmia it seems quite rare. Does everyone go through the parosmia stage in recovery?
So we know from post-viral loss in general, it's about 50% experience parosmia. So it's actually quite common. My feeling is it seems to be more common in COVID, but I think actually there could be some bias in that, because I think people with parosmia are more likely to be referred to me, and they're also more likely perhaps to join patient groups such as this. So we may be seeing, it may only appear more prevalent because we're not capturing the people that haven't been bothered by it. But certainly, you know, it's about 50% of people with post-viral loss in general.
Okay. We've got a question here. If full recovery is not possible, how do we know if we're still having prosmia or if it's just our new normal?
So if you get to a level where you can enjoy your sense of smell and taste, it brings pleasant emotions, and it may not be 100% to where you were before, but it's good enough. I think we can be happy to say that's the point we want to get you to. What's quite interesting is that we've looked at some people who have reported that they have fully recovered, but when we do objective smell testing, we find that they've still got a mild deficit. Now, if they find that their sense of smell and taste is working well enough for them to do all the things that they will want to do, that mild deficit doesn't really matter. So I think it's getting to a point that you're comfortable with. And for most people, I would hope that that's a good sense of smell and taste. It might be for some that it's not as good as they would like it to be, but with time, I think many people find ways to adapt. It's a little bit like a grieving process. And you find ways to take enjoyment from other things as well, texture and colour in food, for example. And so while recovery will continue, you'll also adapt and compensate in other ways.
I'm asked this question a lot also because my sense of smell after 8 years is still actually improving and still changing, but I consider myself to have a good quality of life with the sense of smell that I do have. And the analogy I like to make is that losing your sense of smell and recovering, it's like emigrating to a new country. And when you get to this new foreign land, you're terribly homesick and it feels all wrong and you don't like the food and you don't like the weather and all that sort of thing. But in time, you live there and you adapt and you start to love your new home. And pretty soon, yes, you remember your old country with fondness, but then you develop a new appreciation for this new world that you live in. And I think that, you know, that takes patience. You have to have acceptance for that. And I firmly believe that the brain starts to fill in the gaps after a while. And so, you know, maybe raspberries, intellectually, I think probably raspberries are a little bit different to me than they were originally. But now when I put a raspberry in my mouth, it's the smell of a sunny day in July, and it's every bit as good and refreshing and makes me feel as happy as it did before. So I think we shouldn't underestimate the way our brains adapt in this situation.
We have a question here from Anna. Well, we have many questions, in fact, asking about fluctuations. So people are asking why these fluctuations are happening. What does it mean?
We've never been able to study patients so closely on a sort of regular basis with post-viral loss before. So again, this seems to be fairly unique to COVID, but I suspect it's simply that we haven't studied patients so closely in time. There's some natural fluctuation in terms of variations in nasal congestion, and we all have something called a nasal cycle. And throughout the day, we have a circadian rhythm. So when we lie down at night, our nose gets a lot more congested and the turbinate shelves inside the nose swell up. So when we first get up in the morning, our nose actually is quite blocked, and it takes about half an hour for turbinates to decongest and drain out. And when you have what we call a threshold problem, if the nerves aren't working at full capacity, you need all the odours that you can to get up to that area and stimulate the nerve endings. And if anything is slowing down the passage of odorants, even if it's not at a level that makes you feel very blocked, it will reduce your ability to smell. And so that will be some fluctuation throughout the day. There is clearly a fluctuation in terms of the nerve itself with the strength of prosmia and the strength of background sense of smell, and we haven't really understood that properly yet. You know, it could be differences in inflammation, it could be differences in connections, but we don't really understand that. But certainly the pattern is that the fluctuations get less severe over time, and the number of setbacks seem to get fewer, and the overall recovery seems to be very positive.
We have a question here from Susan, who says, with prosmia, the smell training seems aggravating because the smells are often so strong and chemical smelling. Should I continue to smell train during prosmia?
I think in those cases, it's important to try and find something that doesn't trigger. So experiment with the different things that you use. We know, for example, that citrus can be a really strong trigger. So you may want to avoid the lemons. And Chrissy may want to add, but it's finding something. It doesn't have to be the 4 essential oils. It's anything that you can smell on a regular basis that doesn't make you worse.
Yeah, I would agree with that. I think that with Prosmia, the triggers can be very, very personal. I mean, we know that there are a couple like coffee and roasting meat, for instance, that are known triggers for almost everyone. But the rest of it is kind of down to you. And if you've got really severe parosmia, you have to be, you know, a good detective. Go through your house and look for things that you find palatable. You know, there are a lot of things that have an odor that is not necessarily a food. So, you know, whether that's maybe the leather or wood bark, you know, there are a lot of things out there that that you might discover in your garden or out of doors, or, you know, I don't know, just in your house that are not so bad. And it's the stimulation of your sense of smell, not the thing that you're smelling, that is so important with smell training. So experiment and see what works for you.
And with the surveys that you were explaining, the results for surveys and ongoing surveys, Claire, people are asking where you've got these surveys from, how they can access these.
So we will forward them to Chrissy, who will post them through AbScent and through the Facebook group. So there have been a number of different surveys that some of you will have already taken part in. And when we come around to do follow-ups, we will let you know. If there are trials that are recruiting, we'll also try and post them onto AbScent. We're trying to get some money for a trial at the moment. Setting up a trial takes some time. You have to get approvals. But I'm hoping that we'll be able to come back to you with some trials that people can take part in as well.
That seems it for the question front of things, so yeah.
I see lots of things in the chat bar. Let's see what's happening there. We've got a question here about acupuncture, Claire. I would say acupuncture is probably like a lot of things that have not really been demonstrated useful. What's your feeling on that?
The answer is, I don't think it's been evaluated in a clinical trial. And as I tried to explain, and I'm sorry if I went a bit off track, the problem is that by chance, we know that some people will spontaneously recover. And if they happen to have trialed something in that week, they will associate recovery with whatever they've done, whether it's taking a tablet or acupuncture. I think the one group where acupuncture may play a part actually would be patients with parosmia. I do use acupuncture in some of my patients with facial pain. And when you have facial pain, it's often what we call neuropathic. One of the nerves is firing abnormally. Tinnitus would be another example where you get the hearing nerve firing abnormally. And parosmia could be thought of a little bit like that. It's abnormal nerve function. And there is a gating theory of nerve activity. So if you have a stronger impulse that comes in, it gates out the unpleasant backgrounds, pain, smell, taste, or whatever. And so acupuncture might work in that respect. By stimulating some of the sensory nerves, you may achieve some gating, and it may help with the parosmia. Now, it's not been shown in any clinical trials, but that's the one group where I imagine if it's going to have any use, it might be beneficial. In the same way, other things, you know, simple things we've talked about, for example, using mouthwashes or cinnamon chewing gum, having a more pleasant stimulus also acts as a gating mechanism. So it overrides that unpleasant background smell. And that doesn't just help at the time. It's not simply masking. It's weakening those unpleasant central nervous connections by putting in a more positive connection going in the right pathway. So that sort of thing can help over time. And it's quite similar to models of tinnitus retraining, where you use pleasant stimulus to actually weaken the connections to the unpleasant stimulus.
Great. Anything else, Aidan?
We have a more biological question. What's the difference between a neutralizing antibody and simply an antibody? That might be one you'll quite like to answer.
So essentially, antibodies have different roles. If you have a neutralizing antibody, the idea is it binds to viral particles and stops them infecting other cells. So it eliminates the virus from the body or whatever, the bacteria. Whereas our other antibodies, IgM and IgG, are about priming the immune response to a future infection. So one deals with the current infection, the rest are waiting in the wings, ready for a future infection to come along.
Mhm. And maybe more on well-being here, but I'm getting asked here how to enjoy food currently with an Osmia.
Yeah, maybe I could say something about that. I think a greater appreciation of food comes with a greater awareness of the experience that you're having. And the best way of doing that is a little bit like smell training, and that is to begin each meal by taking a tiny bite of something that's on your plate and really concentrating on the experience, what you might be getting from that, from chewing that food, doing it slowly. Don't throw all the food into your mouth at once and just wolf it down, but really draw your attention to the experience of that one food. And I think that this is a great awareness raising exercise, and really, as with smell training, what you need to do is concentrate on the experience, and that's where it comes from. That's where the awareness comes from. So I recommend that. And as Claire mentioned, it is things like presentation, different kinds of, so a true taste balance, so something salty with something sweet, something sour in there mixed in. A lot of ethnic foods have that in them, so that's a great way to start. For instance, different textures, that sort of thing. You can increase your appreciation of food that way. And Claire, I don't know, would you have?
No, I think that's absolutely right. Sharing experiences, and I think the power of support groups like this is really important. But it's substituting that simple flavour with other things that will enjoy the environment that you're taking your meal in. Now we can enjoy meals with friends again is really important as well.
I think we forget, the whole experience of eating together is so much a social experience. And when you don't have that, when you feel you can't participate, people stop wanting to eat with their families or go out to eat. And that's really, that's a shame, because you really need to be brought back in. One of the things that I found really helpful when I couldn't taste my food was to sit across from someone who really could taste their food and talk about it. And it's a bit like having a seeing eye dog. You've got someone to accompany you on that food experience and try and help you experience what you can get. Because with eating, as with smelling something, you may not get a complete picture of the flavor of the food, in the same way that you may not get a complete picture of the smell that you're trying to smell train with. But you might be getting a smell message. And therefore you might be getting, when you eat, because of course we know that sense of smell is very important in the flavor that we perceive. When you chew your food, you might get some flavor message. And the thing is to then try and work out, what is that message that you're getting? What's that little bit of flavor that you can perceive? So yeah, it takes patience, and it takes people who will help you. And I do think it might be rather fun in a Zoom setting to do a kind of group tasting of something, and talk about what we're experiencing. So watch this space. Maybe that will come in the autumn.
As long as it's not chocolate in my case, I'm fine with it.
Right. What else do we have?
People asking, can you explain why a smell is detectable in first contact but then fades virtually straight away?
So I think it's a little bit about threshold. When we take that first mouthful, when we chew our food, we're releasing a higher concentration of odorants than we will with second mouthfuls. And also nerves have a sort of a decay. So that first trigger will fire a nerve, but then you need to actually maintain a high level to keep the nerve active. So the first mouthful is usually the best, and then it will diminish a little bit. And that's really partly the threshold function.
Yeah.
Yes, that's very frequently reported. So we've got a survey going within AbScent called the Sense of Smell Project, which was started last year, last May. And in that survey, we queried this very subject. So I called them fleeting whiffs. So it's just a short experience of smell that then immediately disappears, and you're not sure whether you actually smelled it or did you imagine it. And that's something that a lot of people report, and I certainly don't know the biological basis of that, but I do know that it's very common.
So I think there's quite a few questions about the slides, and I will give them to Chrissy so that you can come back and have a look at them again. So I'm very happy to share all of those with you all.
Thank you again, Claire. That's wonderful. Right, well, it's incredibly, the hour is up. That went very fast. I would like to thank Claire for coming tonight and sharing her wisdom with us and all the latest research. It's just been wonderful. I know we'll be chatting about this tomorrow in the Facebook group, probably for many days forward. I will be downloading the recording if I get it right this time, and within the next couple of days, a recording of this event will go up onto the YouTube channel of AbScent, so you can look for it there. And then I always post links in the Facebook group, and as well as we will have a PDF of Claire's slides there as well for you. So next week, I am going to have Professor Thomas Hummel from the University of Dresden and Dr. Valentina Parma from Temple University, who are going to be with me, and we will be talking about the results of the Global Consortium for Chemosensory Research survey. So there's two sets of results that have come out recently, so they'll be talking to us about that. We will be taking your questions. As always, Aidan will be wearing his cordless headphones and will be manning the chat bar and the Q&A bar. So until then, thank you very much for attending. Thank you again, Claire. Thank you, Aidan, and good night, everyone.
Well, thank you. Cheers.
Bye.